Good evening, good afternoon, ladies and gentlemen. Thank you so much for joining us for this very informative and empowering session organized by Emergency Medical Services Department of Ministry of Health in partnership with SEED Global. And it's my pleasure to inform us that this is the 120th session sharing information, empowering health workers across the nation. And I know the impact is felt and seen over the years since these sessions, this project started. I'm called Dr. Joseph Gavin Nyanzi. I'm so privileged to be your host this afternoon. And I work with WENS Medical Center that is found in Gaba, Machindia Division, as well as serve as the chair of ethics and professionalism at the Uganda Medical Association. And with me this afternoon, as specialists who are going to be making the presentations to us on the topic of prepare to respond, principles of disaster management. I know this is something that is not very common in Uganda. Usually we hear about the floods, especially in the Masaba region, that is in Mbale. But apart from that, we don't have as many. Maybe the carnages on the road. So I believe that the information going to be shared today will make us be better people offering the much needed support when people are involved in such activities or such situations. On the list of our presenters this afternoon, we have Mr. Juma Said Tusubira. He's a public health disaster management researcher working with the Center for Prevention of Trauma and Injury and Disability at Makerere University School of Public Health. Mr. Juma, you're very welcome.
Thank you.
Yes. The other presenter we have with us this afternoon is Professor Feven Tedela Mitiku. She's an assistant professor of emergency and critical care medicine and a disaster medicine graduate, as well as a SEED educator with Makerere College of Health Sciences. Professor, you're very welcome. Yes. And the third specialist for the evening is Dr. Kitula Hagai Sande, who is an emergency physician, public health specialist, principal medical officer with the Division of Public Health Emergency and Preparedness Response at Ministry of Health. Dr. Kitula, if you're online, kindly unmute and salute the audience. Dr. Kitula, are you online? Okay, maybe he's about to log in, and when he gets on, I will surely be able to introduce him to the August audience this afternoon. Without any much further ado, I'll take this opportunity to invite everyone on board to share your expectations for this session. What are your expectations? I believe this will help to guide. Of course, our presenters already have prepared presentations, but I know if you have particular expectations, then they could gear their presentation towards that. Feel free to post in the chat, as well as if you can put up a hand, I'll be in position to give you an opportunity to share your expectation with the rest of us. As we do that, please share the link with your friends. Let them not miss out on this very important session this afternoon. The time now is to share our expectations. Anybody, you can either put up your hand or post in the chat. And since I'm privileged to be the chair this afternoon, Okay, I see Dr. Timothy Muyimbo. Dr. Timothy Muyimbo, can you unmute and share your expectation for the afternoon? You are unmuted now, Dr. Timothy. Feel free to share your expectation, at least one. Sorry, I ambushed you, but that's my privilege as a host for this afternoon. Okay, as Dr. Timothy comes on, Remy Sebaiga from the chat says, how quick can I respond to emergency with limited resources? Then Wilfred Akenda says, assessment of crisis in an emergency situation. Dear friends, let's continue to share our expectations. Wow. Elijah Bongoke says, is from Zinga Island, Health Center 3. Okay. Elijah, can you share your expectation, please? So happy to have you on this call this afternoon. Okay, Dr. Moses Nasimu says he expects to know about transportation or evacuation of a patient with polytrauma. Transportation or evacuation of a patient with polytrauma. Thank you, Dr. Nasim. Any other expectation? We will very shortly call upon our first presenter, and that will be Mr. Juma Said. But before he comes on, I really encourage us, please share the link in your WhatsApp groups. Let people join in, as many as they can, so that we can benefit from this very critical information that is going to be shared by our specialists this afternoon. Okay, thank you, Simon. Mr. Simon Muhenda says he needs to know about quick triage when you are alone at accident and emergency unit. I hope Doloka Kalafa says, my challenge is the referral system. How do we combat this in Uganda? Referral system. Then Kamahoro Christine wants to know about the escalation protocol. Escalation protocol. Betty Naranji wants to know or to hear about resources prioritization. Resources prioritization. Yeah, I trust we're going to have information about the above as our presenters make their submissions. I want to check if Dr. Chithula is on call. Okay, Dr. Chithula, you're very welcome. Dr. Chithula Hagai Sunday is an emergency physician, public health specialist, is a principal medical officer with the Division of Public Health Emergency Preparedness and Response at Ministry of Health. Dr. Chithula, kindly salute the august gathering this afternoon. You've been unmuted.
So, thank you so much, colleagues, and thank you for arranging this. I'm glad and excited to be part of this meeting today. Thank you so much. We shall discuss during the time that I'll be given. Thank you.
Thank you so much, Dr. Chithula. We are so glad to have you on the call. Okay, before we begin our first presentation, I'll read some more expectations and then we'll be good to go. Mandela Patricia says, what strategies can be put in place to manage disasters during emergency? What strategies can be put in place to manage disasters during emergency? Davis Mubiru says, how best can we involve the laboratory team during emergency crisis? Andrew Okirol, thank you, says hazard mapping. He wants to know about hazard mapping. Kavagambe Enoch, what is the difference between a hazard and disaster in a health setting? Then James Peter Odikor, salt triage and start triage, how to use them. Salt triage and start triage. How do we use these in an emergency? And then Shadia Nakakande, in case I'm one of the victims, what do I do? Very important question. And then as I come to a close of this session, Biachika Peterson, how can we handle disasters involving bleeding citizens? And then finally, for now, Mr. Sharif Sebulime says, my expectation from this is to be educated about the SOPs and guidelines for emergency response plan in Uganda. For the rest, thank you so much for all your submissions. Part of my team here is following up the discussions in here, and we'll make sure that we get all these to our presenters. So without any much further ado, I will welcome Mr. Juma Seitu Suvila to give us the first presentation titled Common Disasters, Resource Mobilization During Disaster Management in Uganda. He's going to make this presentation in 20 minutes. The count starts now. Thank you. Mr. Juma, you're welcome.
Yes, thank you, everyone. Good afternoon. My name is Juma Seitu Suvila, as I've been introduced, and I'm a public health disaster management researcher. I'm a research associate at the School of Public Health in the Department of Community Health and Behavioral Sciences. And I also work with the Center for Prevention of Trauma, Injury, and Disability, the C-Triad, also under Makerere University School of Public Health. So this is an interesting discussion for me, and I want to give you an overview of some of the things I hope to cover. I hope to give you an overview of disasters, the common concepts around disasters, the common disasters we have in Uganda, some case studies, and the general overview of response to disasters. So I want to start with this video. So I was born in Kasese, and Klembe Mines Hospital was one of the most advanced hospitals that we had in the region. So in 2013, a flood swept through the district and damaged some parts of the hospital and other areas. And then in 2020, the floods came back and they finished what they had not completed in 2013. The hospital was swept, communities were broken down, the mortuary was swept, bodies were flowing down, bridges were destroyed, wards flooded. And if this could happen to such a big facility that was maybe almost to a level of a regional referral by those standards in those days. So what do you think is the general picture in other places? So let's move to the next slide. So in 2025, according to the CRED database for disasters in the world, we had about 358 disasters that were reported. And of these, over 110 million people were affected, and hundreds of billions of dollars were destroyed in damages. And we lost about 16,000 and more people from disasters. Next slide. Okay. So when we say disaster, what do we mean? So a disaster is a serious disruption in the normal functioning of a community or society. And the major characteristic here is that it has very huge losses and it exceeds the ability of the affected community to cope using their own resources. And so the other thing I would like to define is an emergency. So an emergency is a state in which normal procedures are suspended and we take extraordinary measures to avert a disaster. So in an emergency situation, is we have very, very serious threats and that are putting many lives at risks, and there is a high likelihood of losses. So how do you relate a disaster and an emergency? So you can have a disaster and it can produce several emergencies in it. So the disaster is bigger and the emergency is a result. A disaster can have many emergencies in itself. And also when some of these emergencies are not handled well, then they can escalate into disasters, so that you now need external support to be able to respond. So a disaster has mainly 4 components. We talk about a hazard, vulnerability, capacity, and risk. So, and these pictures can help us to discuss this. So in the first picture, you see we have this motorcycle, and then you have probably the people don't have, the child doesn't look so much risky compared to this other picture where we have over 5 children, and even the children are seated at the edge of the motorcycle. So by just that, those different factors are going to determine the kind of disaster that's going to happen in case any of these motorcycles crashed. So let me break this further. Next slide. So for disaster risk, we have to balance a hazard. So a hazard can be something that can cause potential harm. For example, falling in water, and then maybe you can be bitten by a crocodile. And then vulnerability is what predisposes you to that hazard, what exposes you. So this man, as he's walking on the line, he can either fall off, or he's walking on the line. Maybe if he was walking on a bigger surface, he would have been safer. And then he's also holding another stick. So now, and in him, his capacity to balance on that line is going to determine his likelihood of falling in the lake, and also maybe his capacity to swim and all that. So this is the bigger this is the concept of disaster risk. Slide. So a hazard, what I'm calling a hazard can be a natural or human phenomenon that can affect human life, property, to the extent of causing a disaster. And hazards are many. We have natural hazards, we have man-made hazards. For example, if you have a sharp knife, if you have maybe a cliff that is, tall and steep, that can be a hazard. And hazards differ by level. So by how much of the hazard you're exposed to, how much the magnitude of the hazard, the dose of the hazard, if it's maybe a chemical, and then duration, for how long have you been exposed to the hazard? And we'll get this. So the other issue is exposure. So exposure is in a disaster means that you're looking at the people, systems, elements that are in a hazard zone, that are interfacing a hazard. So, for example, you are near a river, you are in a flood zone, you are in Chitezi recently, people who are on the border bordering the landfill. So that is exposure. Then the other aspect is vulnerability. So there are characteristics that predispose individuals, systems, and communities to harm. So, for example, you find you are in this area, it's a flood-prone area, but then your house is not raised, or you already have that internal weaknesses, weak infrastructure, poverty. So maybe a fire starts out and you can't even, maybe you can't afford, you don't have a fire extinguisher with you. You maybe fall in water, then you can't swim. So now that increases your likelihood of being affected by hazard. And the opposite of vulnerability is capacity. So capacity, these are basically resources that are available to an individual, to a community, that can help you to resist the impact of a hazard. So, for example, how a community is organized, or other skills and attributes of individuals that can help you to cope when you are faced with a hazard. So, and then the interaction of all these is what we call risk. So risk is the probability that the hazard can occur and cause losses. And how we describe communities, people, as the elements at risk, people at risk. So that, and risk, as I've said previously, depending on your vulnerability, the level of hazard you are faced with, your capacity to cope. So the level of risk is different. So there are people at high risk, low risk, and moderate risk, and we'll see some of these. So we have a disaster cycle. So a disaster happens in phases. So the first phase is we have the preparedness phase. This is before the disaster has happened. And then after between the preparedness phase and response phase is where the disaster actually strikes, between the blue and red. And then once the disaster strikes, then we move into response, where we are saving lives, where we have the incident command systems, we have protecting property, evacuating people. Then when response is usually for a few days. And then after that immediate phase, then we continue supporting the affected communities to recover, to slowly to start rebuilding economically, social services, health services. And then when communities recover, then we begin planning, how do we mitigate future disasters? And then the cycle continues like that. So disasters can be natural, technological, or in between. This is by the hazards causing them, but also by the speed at which of onset. We have those that are rapid and those that are slow. Let's proceed. So slow onset, these are disasters that take time to build. They build slowly. For example, drought and desertification. A drought doesn't appear in 1 week, but it's a series of weeks. Famine, pests, volcanic activity. We have receding water levels in some communities, rising water levels, like the water keeps rising, and we have those that we call slow onset floods. Then for the rapid onset, next slide. So these ones happen spontaneously, quickly, in a short time. And this is where we have flash floods, like when glaciers melt after storms, cyclones, tornadoes, lightning, earthquakes, all these things happen in a short time. Next slide. And then we have the technological, because chemical spills, wars, these are mainly man-made, from man-made hazards. Crashes, ergonomic hazards at work, all those are man-made. Next slide. Continue. Next. So currently climate change is exacerbating the disasters. It is affecting hydrometeorological conditions like rainfall. And so there is a lot of rainfall in some places. Then there are prolonged dry seasons in others. And all these are affecting communities. Maybe they now don't have enough food, and yet exposures are increasing and leading to a lot of risks. So we need to have it at the back of our minds that climate change is a big factor to some of these disasters. So I want to go to the common disasters in Uganda. So we have 7 major hazards, and drought, floods, hailstorms, and these are also distributed according to regions. So drought is mainly in Karamoja and Teso regions, and then floods are mainly in Teso and Bugisu sub-regions. Landslides are Bugisu, Rwenzori, Kigezi. Thunderstorms are mainly around the Lake Victoria Basin, but we also have them in Busia, in Bushenyi. Earthquakes are along the Rift Valley, that the western part of Uganda that has the Rift Valley. Those are the main areas exposed to earthquakes. And we also have the cascading hazards, or hazards that when they ramp up. So you find the region is exposed to more than one hazard. And this is common in southwestern Uganda, in eastern Uganda, and around the mountainous regions. You find they have floods, earthquakes, landslides. They have everything in those areas. So next slide. So these are some of the hazard risk profiles. The first one is for drought. Then the middle one is for landslides, and the last one is for floods. So the darker the color, according to those keys, shows the areas that are vulnerable. Next slide. And this is the hazard calendar of Uganda. So we now, for example, when we go to floods, the high intensity floods are expected in March, April, May, and then September, October, and November. So each of these disasters, we know the seasons they are likely to happen. Next slide. So this is in terms of frequency of occurrence, and as you can see, floods and hailstorms are some of the commonest. Next slide. So there are several effects of disasters, and we usually group their impact by people who are affected, injured, displaced, and those that have died. This is in terms of humans. And as you can see, the numbers are in thousands and broken down by different. And these are in many. We have the annual state of disaster report produced by the Office of the Prime Minister. Next slide. So one of the, as you can see there, floods are one of the highest disasters affecting people. And in terms of widespread, we also have drought and prolonged dry spells because of issues of water scarcity affecting wide communities. Next slide. So I want to zero in on floods because I have a special interest because of where I was born. And so floods in Uganda are mainly due to heavy rainfall, encroaching on wetlands, and rapid urbanization. Next slide. So we have slow onset, the flash floods, by the time which they take to occur. And in Uganda, we have the floods along rivers, those that come as runoffs, those that are floods from the water levels in water bodies rising, and also urban flooding. So right now, those are some of the examples of flooding. As you can see, these are different scenarios and different areas, and these are the different kinds of floods. So this is the impact of floods in Uganda. Over 72 people died in 2020 from floods, and this is their impact. Let's proceed. I want to come to, I've talked about vulnerability, and people who are exposed to floods are mainly in informal settlements, where areas where we have poor drainage, poverty, and limited preparedness, and also weak enforcement of environment policies. So floods affect health in many ways. Immediately a flood happens, people drown, injuries, we have hypothermia, animal bites, and then when floods are in the intermediate phase, we have trauma, contamination of food, disease epidemics, and then long-term effects, disability, poverty, diseases associated with impoverished conditions, because communities exposed to floods take long to recover. Thank you. Next slide. So, and in Uganda currently we have, by statistics done by the CTRIAD, about 3,000 people die by drowning every year. And these are mainly children, fisherfolk, rural communities, and the urban poor in flood-prone settlements. And many of these are disaster-related. So, and next slide. So people, when water comes, then you can't swim, then all this, you're submerged. So apart from drowning, there is trauma, cuts, infections, electrocution in urban areas. So I want to give a case study of one or two places, Kasese and Kampala. Next slide. Next slide. Yes. So Kasese faces recurrent floods because the town is around the flood zone of the Nyamwamba River, which is also a network of like 5 rivers. So each year there are like the river floods about 6 times on average since the 1960s per year. And this has increased. Okay. So as I've shown you in the video, flooding destroys health facilities. It interrupts the services you have. There is no power. Then there is reduced physical access to the facility. If you have an ambulance, you can't even drive it there. There is no road. You can't carry the equipment across these regions when disasters are happening. Next slide. Let's continue. So in Kampala, we have urban floods, and we have over 100 spots that flood within the city. And many of these have a high volume of water. And when there are floods, ambulances can't move, people can't move. And let's continue, next slide. So, and it affects so many things. So, next slide. So what happens in a disaster is that whatever has been functioning normally is put to a halt. And we enter a state where there is much confusion, much panic, and much uncertainty. Let's continue. let's go to some of the, so this is a study done in Kasese, where we found that a third of the health facilities in Kasese, in the flood-prone sub-counties, have flooded within the last 5 years. So this shows you that this is not theory, but it is actually happening in our communities and the places where we work. Next slide. So I want to go to disaster response. How do we, what is being done about these disasters? And many of us think that there is nothing done because it is always disaster. But in disaster management, we have a couple of things. We have prevention, where you try to prevent a disaster before it happens, mitigation, trying to reduce its impact, managing risks, reconstruction, and preparedness. Next slide. So in preparedness for disasters, you are trying to forecast, look ahead and see what you can do before the disaster strikes so that you can help the community to respond better. Next slide. So, and when preparedness ends or when preparedness fails in some cases, then you'll have to respond. So in response, you are trying to meet basic emergency needs of survivors. So if it's a landslide, you are searching where the bodies, where people, how many are injured, looking for the needs, food, shelter, and we want to generally to reduce the impact of the disaster on the community, to reduce the human suffering, to save lives, and also to build the capacity of survivors so they can improve their response. A good response actually gives the community capacity to actually withstand the other phases of a disaster. So, of course, I've discussed from the health perspective, these are some of the problems you will be responding to when there is a disaster. There's water, no water supply. People are on the move. There is large-scale displacement of people. People are overcrowding in emergency housing. Then you are feeding lots of people with emergency food supplies. We are stuck with a lot of dead bodies and carcasses. We have vectors, rodents, and then some measures are relaxed. You want to give someone blood transfusion. So do you first wait for the normal protocol or you give the blood that's there? Then psychosocial and mental health conditions for the community, but also for the health workers, the responders are usually actually very affected because of what we call a severe complex. So you feel like you want to save everyone and you forget yourself and you're actually taken up in the disaster and you have badly affected. So I have like 3 slides to conclude. So, and internationally, we have the Sendai framework that guides all disaster risk management globally. This is like the SDGs in disaster management. And it prioritizes one keyword, risk, disaster risk. Let's understand the risk, strengthen your capacity to govern the risk, and invest in reducing the risk. And they introduce that phrase, build back better, so that after the disaster, the community is better than it was. Next slide. So in Uganda, we have policies and frameworks that guide our disaster response. The national policy, the Health National Adaptation Plan for Climate Change. Next slide. And in terms of disaster response, all response, this is the structure. So it is the president that is in charge of, that has the mandate, and then which he delegates to the office of the prime minister, where they have a department of relief, disaster preparedness and management. And then the structure goes to the district, where we have the OPM constitutes the National Disaster Task Force. You saw these structures in COVID. And then from the national, we go to the district and then to the village. Next slide. So These are some of the actions. I'll not go into them. Next. Let's continue. So at community level, we try to strengthen service delivery. If you already actually having the malaria burden in control and people are already having some of these facilities, then it may not be difficult for them to respond when a disaster comes. There are also what we call community early warning systems, whereby communities monitor hazards. They are given forecasts ahead of time so they can get out of the way of disasters. Let's proceed. So I wanted to highlight this since I'm talking to this group. So from this study that I led in Kasese in 2024, we found that most of the facilities, actually none, was completely prepared for like a flooding disaster. And I want to show you how this, just a brief breakdown. Next. No, the one before that. So this is like one of the areas we're asking them about emergency protocols. So we ask these facilities, so do you have an emergency plan, an emergency response unit, a focal person to respond to a disaster? And as you can see from all these, about 36 out of 43 of these facilities, and these were the most flood-prone sub-counties in the country. They were not having these things in place. Let's continue as I conclude. So we are talking about creating resilient health systems and that can respond better. So we need a trained health workforce where you are also informed and you know how these disasters happen, and where we are integrating other information systems. When Uganda National Meteorological Authority releases a forecast, as a health worker, what do you do? As an EMS officer or someone, how do you respond to that? And then how do you continue services when there is all this disruption? And then how can we have like our facilities, technologies, and products that can be sustained even when there are disasters? Let's proceed. So this is somewhat I found that to be a very, very a resourceful person in the disaster, these are some of the capabilities you may need as an individual or an organization to be able to assess a situation, to make decisions when there is uncertainty, to communicate communication when there is all this pressure, incident command principles, clarifying roles during disaster. During disaster, one of the major problems is we have too many responders. Everyone, you have 10 NGOs, all of them are bringing jerry cans. No one has thought of hand washing. So clarifying roles becomes important. And then solving problems when situation is deteriorating. So thank you so much.
Wow. Thank you so much, Mr. Juma, for such a wonderful and very well detailed presentation. And I guess we are now about almost 35 minutes rich with information about disaster management in Uganda. Yes, please keep those hand claps coming, appreciating our previous speaker. And for those that joined in when Mr. Juma was already on the call, I would love to let you know that this is our 120th ECHO session that has been organized by SEED Global in conjunction with the Emergency Medical Services Department at Ministry of Health. You can imagine those are 120, that's about 120 times 2 hours, 240 hours of information enriching us in different aspects of healthcare management. So thank you so much, Seed Global. And I also want to acknowledge Dr. Anne Alenyo Gavirano. Thank you for responding to the questions in the chat. Thank you very much. I know this is your area of interest. So thank you so much for responding to all those questions. It means a lot. So at this juncture, I'm going to invite our next presenter. That is Professor Fervent Tedela Mitiku. She's an assistant professor of emergency medicine, emergency and critical care medicine, disaster medicine graduate, and seed educator at Makerere College of Health Sciences. Her topic of presentation is resource prioritization, ethical principles, challenges and recommendations, and pre-hospital care of victims of disaster. Professor, you're welcome.
Okay, hello everyone. So we are happy to be here. So I am Fervent Tedela Mitiku, an assistant professor of emergency and critical care medicine, originally from Ethiopia, but currently a seed educator at Makerere Hospital. I have a master's in public health, and I'm also a disaster medicine graduate. So I'll brief you about resource prioritization and pre-hospital care or medical care in pre-hospital setups during disaster management. So our motto for today is making every resource count when the seconds matter. And the second motto would be pre-hospital strategies for resilience in a crisis. So the first topic of discussion will be how do we prioritize resources, and then why do we prioritize resources? So the reason is we have limited supplies. As usual, we have limited healthcare professionals that can manage disasters, and we have also limited funds. And due to those reasons, we need to allocate these resources to save lives, to stabilize infrastructures, and then to ensure fairness. While we are prioritizing resources, the things we should consider is we need to be efficient, and then we need to maintain equity and sustainability. And then whenever we make decisions should be what? Data-driven, or it should be evidence-based to prioritize those things. Next slide, please. So before we start prioritizing resources, or before we assign resources, we need to do a hazard vulnerability assessment. As Mr. Juma said, Uganda has already identified the hazards in the country, but let's say the other country didn't analyze the hazards that are present currently. So what do? We do a hazard vulnerability assessment, and hazard vulnerability assessment can be done at a community level, or it can be done at a hospital level. As a community level or as a country level, we have different stakeholders that are going to participate in this hazard vulnerability assessment. So these stakeholders can be Ministry of Health to give emphasis on the health impact. The other stakeholder might be like the utilities department, those working in the power stations, those working in the telecommunications and in the power. And the other stakeholders might be what? Police officers, the military, the fire department, the governmental officers, since they are the one who's going to give us the resource for this. So we need to involve all the stakeholders. When we do a hospital hazard vulnerability assessment, everybody should be involved, starting from the administration up to the level of the security, and external NGOs and the fire department and the police can also be the stakeholders when we do the hazard vulnerability assessment. So what's the first thing we do is identify the hazard. Mr. Juma has already stated that there are different hazards, which are natural, technological, or human-made. So what's common in our area should be identified first. Those that are occurring in the north might be different from those that are occurring in the southern region. So you need to prioritize, or you need to identify those hazards that are occurring in your region. The next thing you assess is the vulnerability. Vulnerability means what population is at risk. Is our infrastructure strong enough to sustain that disaster, and the third is, do we have the resources to manage it if a disaster occurs? So we have identified the hazards, we have assessed the vulnerability, and then the third thing we're gonna assess is the impact. So is the impact on the health, is the impact on the economy, or is it gonna affect the environment? Those things must be assessed thirdly. That means on health, meaning the patient it might result in what? Infectious disease, it might result in injury to the people of that country, it might result even to death. And then the other assessment is about the economy. Is the economy gonna be affected temporarily, or is the economy gonna be affected for a long term? It depends on the type of the hazard. After we identify those hazards, the next thing we do is prioritization. That means you need to rank the highest and then rank the lowest based on the likelihood and the severity of that disaster. After we rank those things, we develop a strategic plan or a strategic operation plan, and then we strengthen for resilience. So there are different tools that you can use for assessing the vulnerability or to assess the hazards, but the commonly available, or it's online available Excel sheet that you can use is the Kaiser Permanente tool. So you will assess the event, you will assess the probability, and then you will assess the impact on the human, the property, and the business. And then you will assess if you are prepared for that, how your internal responses and your external responses. So, as you can see here on the first column, the first event here says active shooter. So is active shooter a threat for African community? No, right? So this will be what? A lowest priority. But there were history of what? Bomb threats. There is a history of civil unrest. There is a history of drought, flooding, and earthquake. So you will assess the probability or the likelihood of that disaster occurring and rate it from low up to high. And then the next thing you assess is, have you ever activated the hospital incident command system or the country's command system because of that disaster? If you activated it, you will tick right. And if you have never activated because of that disaster, you will tick no on that. And then after that, you assess the human impact. Human impact means, did it result in death? Did it result in injury? Did it result in illness? So this will be again assigned as low, moderate, and high. And then you will assess the property impact, the business impact. After giving numbers for those things, the third thing you assess is the preparedness. That means, do you have a plan for that? Do you have trained professionals for that? Have you had drills or have you tested the plan? So those things should be assessed, and then you should be labeled. And then if the disaster had actually happened in the country, you will assess your internal response and your external responses. And then everything will be what? Numbered. And finally, you will have the relative threat or the risk. And the Excel sheet will automatically calculate the percent for you. After the calculating the percent, next slide, the Excel sheet will give you so the Excel sheet will give you a report of the data. That means, as you can see on the left lower corner, there are 10 listed high priority disasters. The disaster report or hazard vulnerability report is from Ethiopia. So the top 10 hazards in our society is mass casualty events, trauma, civil unrest, the droughts, and things like that. So what's the importance of having that? We are gonna prepare for these top 10 disasters first. And then if we have extra resources, if we have extra human resources, we can prepare for the rest. But we have to give priority for what? For these 10 things. We have to be prepared. We need to have people, we need to have resources, and we need to have the space for everything. And it will be an easy exercise for you. You can find it online. The link is available here. So it's accessible. You can use it to assess your hazard vulnerability of the country and it should be done what? It's not a one-time thing. You have to do it what? annually. That way, a disaster at this time might not be a disaster for next year. So the world is changing, the environment is changing, so you have to do it. You have to do the analysis at least annually, and then you have to revise your plan and things like that. So how do we prepare for the resource? The preparation is different for preparedness phase, and it's different for the response phase. So during the preparation phase, the first thing is the planning. That means having the hazard vulnerability assessment, and based on that, you prepare resources. So what are these resources? The first resource we're gonna prepare for is training proper health professionals that can respond for the disaster. You need to have a backup health professional. That means during a day-to-day activity, you will have assigned nurses and physicians in the hospital, but when a disaster strikes, those might not be enough. And then in those conditions, you need to call back what? Off-duty nurses, off-duty physicians. You might need to call volunteers and things like that. So you need to prepare ahead for those things. So you need to prepare for human resource. The second is you need to prepare for materials. That means based on your hazard category, prepare the consumable and non-consumable materials. And then the third thing you're gonna prepare for is for space. Let's say there is a mass casualty in a road ahead, and then there are like 60 patients that's gonna come to the hospital to be managed in the ED. Your ED can only manage how many patients? 10 patients. So you're not gonna handle those 60 patients at one time. So what are you going to do? You need to increase what? Your surge capacity. So during day-to-day activity, you treat patients where? In the ED or PD, or you treat them at the theater, you admit them to the wards or to the critical care units. But this might not be enough during disaster times. So during that time, what do? You might use the corridors. You might use the cafeteria of the hospital to manage those patients. You might need to use the parking area of those hospitals. So you need to prepare for those things as well. And then you need to strengthen your governance and your organization. After planning for all those things, and then after having a strategic plan, the next thing is training. Training means you need to train all the health professionals as well as all the volunteers. And then you need to do drills. Drills means it can be a tabletop exercise or it can be a functional drill. What's the benefit of that? Is to assess if there is gap on the plan. And then if you assess that gap, you will what? You do the training, you do the drill, you identify the strengths, you identify the gaps, and then you will write what? An after action report. That after action report will help you to analyze the gaps, and then you'll fill those gaps, and then you will be better when the actual disaster happens. The third thing you're gonna do on preparation phase is the mutual aid agreements. That means you can't do everything by yourself. You don't have the resources to do things by yourself. So you need to have agreement with the police when there is need. You need to have agreement with the fire department. You need to have agreement with local and international NGOs when you need more resources. Those things should be done what? In preparedness phase, not during the response phase. After you acquire all these resources, you need to stockpile them, and then you have to put them in a proper position. You need to have a disaster store that can be used only when a disaster strikes. So this is all the things you do during preparation phase. When we come to the response phase, let's say disaster struck, you're called to manage those patients. What's the first thing you do is you have to assess the scene first, and then you have to activate the incident command system. After activating the incident command system, you will deploy all the resources, including the human resource, the supplies. You need to align the space, and then you need to strengthen the system. And then if there is a need for additional supplies, you need to procure. When you procure for additional supplies, please always stick to local suppliers, because international suppliers, it takes time for the supplies to get there. So rely on the local suppliers first. And then when respond, you have to be what? Fast. You need to respond fast, because our priority is what? saving lives. While you are responding for the disaster, you need to track your resources, right? How much human resource do I have? How much consumable resource do I have? Unless you track it, you won't know what you have or not. So you need to have a real-time data monitoring and feedback mechanism. And this preparedness and response phase should be what? Integrated to save lives. Next slide, please. So what are the ethical principles when we allocate a resource? Is the first thing is saving lives. That comes first. That means you need to prepare for medical aid. And when the disaster is like, when let's say there is a fire, and forest fire, and then there are people around there, so you need to do what? Search and rescue. You might need to evacuate some of the people over there. So those are the first things. The other thing is we need to restore essential things like electricity, water, and communication. While doing that, we have to be what? Equity. We need to assure equity and fairness. That means we need to protect the vulnerable groups like the children, the elderly, the women, and the disabled ones. And you need to sustain. You need to have a sustainable resource. Next slide. So the practical steps have already been discussed, like do your hazard vulnerability assessment, and then supply resources based on the need. That means the medical care, the food, the water should be equipped first, followed by utility and transport restoration, followed by long-term recovery. And then you need to have a good coordination. You need to have a good monitoring and feedback mechanism. Next slide. So what are the challenges when we come to resource allocation is, as you all know, resources are scarce and there is a tough trade-off. And then there might be what? Logistical bottlenecks. Let's say you have the resources, but you can't transport those resources to the area because of what? Roadblocks, or you can't access the airports. Let's say you have the resources, but the political system or the society or the cultural practice is pressuring you not to respond. And the other challenge might be, there might be a data gap in recording. So what do you do on those things? So there are some recommendations here. So some of the recommendations are to adapt a hybrid modeling system to ensure that there is speed and fairness. And then you need to invest on local capacity. I'm going to give emphasis on that. Invest on local capacity, use technology. That means use AI and drones to what? Monitor and then for feedback. The other is we have to plan ahead. Prepare is the motto for resource prioritization. So when we conclude about resource prioritization, it's the backbone of disaster management. You need to balance efficiency with equity and sustainability, and you need to have evidence-based planning, and coordination is a must. Next slide. So the next thing we're going to discuss is the pre-hospital care in disaster victims. So the objective is to save lives through rapid triage and stabilization, to prevent complications by giving early interventions, and to ensure that the patient is transferred to the appropriate hospital. And then you need to coordinate the responders as well as the resources together. So what do? There is an incident in the highway, and then you are called to the scene. The first thing you have to do is assess the scene safety first, because we don't want to become victims ourselves. So assess the scene and then activate the incident command system. And then this incident command system must have what? A clear coordination and communications. And this communication pathway has to be what? Multiple. If one doesn't work, you have to use a different one. And then who are the participants in this medical management? The first is emergency medical technicians might be present, paramedics, nurses, and physicians. That can be general practitioners or other specialty physicians. So you get there, you have established your system. What's the first thing you do? Triage those patients. We have different pre-hospital triaging systems. We have the SART, we have the SALT triaging systems, but the easiest is the SART adult triaging system. It's a simple triage, and management system. So you just classify patients into two categories, those that can walk and those that cannot walk. So if the patient is able to walk, that means his respiration is normal, he's perfusing well, he is what? Conscious. Those patients can be what? Triaged to the green area, and they can be transferred to the hospital. They can be managed hours later. Nothing will happen to those patients. But let's say a patient is not walking. What do you assess next? The next thing you assess is if the patient is breathing spontaneously or not. If the patient is not breathing spontaneously, you position the airway or you open the airway. After opening the airway, if the patient is breathing spontaneously, you transfer the patient where? To the right side for basic life support interventions, and then you transfer the patient to the ideal hospital. But let's say the patient, you open the airway, he's still apneic. What do? You try those patients where? To expectant area or black area. Why? Because in disaster setup, our priority are not what? Individuals. It is the public at large. So you need to give priority for those who have good prognosis, those who have good functional outcomes. So those who are triaged black will be given what? Just palliative care, and then we will wait for them for the natural course to continue. So let's say the patient is now walking, but he has spontaneous breathing. What do you assess next? The next thing you assess is the respiratory rate. If the patient is what? Tachypneic, he will be immediately triaged to right side for immediate intervention and to be transferred to the hospital as early as possible. But if the respiration is normal, the third thing we assess is the perfusion. So this perfusion can be assessed using the radial pulse or the capillary refills. Also, if the pulse is absent or if the capillary refill is delayed, the patient will be triaged where? To the right side for securing IV lines, and then he'll be transferred immediately to the hospital for definitive management. Let's say the patient is breathing spontaneously, the perfusion is good, but the mental status is what? He doesn't obey commands. These patients also go to the immediate area or the red area. But if the respiration is normal, if he's perfusing well, and if the mental status is normal, they will be triaged to the yellow area. So we have triaged those patients. What do we do next? Let's say you triage the patient to the right side. The only thing you're gonna do is what? Manage the airway. If the patient is having active bleeding, you can apply direct pressure followed by tourniquet application, and then they have to be transferred where? To the hospital for definitive management. We don't give definitive care at the field or at the disaster site. We just provide life-saving interventions and then transfer them as fast as we can. We can also give them psychological first aid, and this can be given by like the volunteers and the others. And then we can transport or evacuate these patients using what? Ambulances, helicopters, and other improvised vehicles based on the availability. So what are the challenges when we manage patients in a disaster setup? There will be what? An overwhelming casualty numbers. That means the number of patients and the number of healthcare providers that are gonna give care are gonna be what? Mismatched. So how are we gonna handle that? Is gonna be one challenge, and then the second will be what? We're gonna have limited equipments, and then we're gonna have limited trained professionals. And let's say we have enough resources, but the infrastructure is damaged. That means it's gonna delay what? The evacuation. And then we might have difficulty in maintaining patient records. So what do we do to prevent that? The best practices are to have a pre-positioned, trained health care provider, have a pre-positioned adequate supplies. And the next thing we do is do frequent tabletop exercises or disaster drills with the pre-hospital providers as well as volunteers. And then if there is a documentation gap, you need to use different mobile apps and other things to track the patient records. And then you need to have a strong referral pathway to strengthen the outcome or to decrease mortality. So in conclusion, our priority is saving lives, and you need to save lives. You need to have effective triage. You need to have stabilize those patients. and then we need to coordinate well to reduce mortality, and then we need to strengthen the system for resilience. And I think that's it for me. If you have any questions, you are welcome.
Wow. Thank you so much, Professor Faven, for a very wonderful presentation. I hope we all have our questions written down. Yes, please keep those claps coming to appreciate Prof for a very wonderful presentation. At the end of the presentations, we have one more presentation to go. We'll have an opportunity for having direct questions to our presenters. Yeah, allow me to take this opportunity to invite our next presenter. And I know for most of the questions that have been submitted in the chat, Dr. Anna Lenyo has done a very good job in responding to those questions. Thank you so much. At this juncture, I'm going to invite our next presenter, who is making a presentation on leadership structures and referral pathways for disaster management. And that is none other than Dr. Haggai Chithula, who is an emergency medicine physician, public health specialist, principal medical officer in the Division of Public Health Emergency Preparedness and Response at our Ministry of Health. Dr. Chithula, you're very welcome.
Thank you so much, my colleagues. And thank you for the previous presenters. I'm glad for the stride that have been made. I will also ride on that to make sure that we take you through our incident management system. We have to know that all those hazards that have been presented really, they need also a response that needs to come to them. So as government, we have structures that are activated when there is an incident. So that's what we call the incident management system. So today we're going to look at going to define the incident management and its benefits, understand the IMS core functions, we describe the concept of operations, and then we define the incident management internal communication. And I know after the end of this presentation, this will answer some of the questions that have been asked. So next, so we shall talk about the purpose, the core function. So look at the purpose and roles of the incident management system. So we need to ask ourselves, what is an incident management system? So why do we need it? How important is it? So we're saying that the incident management system is an emergency management structure and a set of protocols that provide an approach to guiding government agencies, the private sector, non-government organizations, and other actors to work in a coordinated manner. An IMS is the combination of facilities, equipment, personnel, procedures, and communication operating within a common organization structure designed to aid in the management of resources during the incidents. And for those of you who really have participated in either the public health emergency like infectious diseases or disasters, you have seen how this is being applied. And the benefits of this is that it meets the needs of all incidents. That means starting from either the infectious or the environmental disasters, all that falls into those categories. And it allows personnel from a variety of agencies to integrate rapidly into a common management structure. It has clear lines of accountability. There's efficient use of resources in terms of coordination. It incorporates measurable, achievable objectives. And also it avoids multiplication of efforts. So when I talk about incorporate measurable, achievable objectives, you know that as we shall go along, we shall find that our incidents are managed by objectives. For example, if we have mudslides in Bududa, it means our objective will be either to identify the casualties, put them in a safe place, and give them what we call immediate medical needs that are required. Some of them might have gotten fractures, some of them may be having open wounds, some of them may be having, maybe even including children, may be in those places but may not have been immunized against some of our non-killer diseases. So what we do that we scale it up, we incorporate other measures, make sure that we achieve it by objectives. Once you have taken people out of danger, they are stabilized, and we know that we have achieved that objective, we can close the incident and then let other agencies take up. If it is let's say an infectious disease like Ebola, we can say that until we complete the 2 intubation periods of Ebola, then we shall say that this incident is over. So that's what it's called management by objectives. Another thing I can say, probably, if something has taken up the media, maybe social media or media has gotten interested in certain event, so we may make sure that probably we manage that event until it's no longer something that is that's in the media space. So the one another benefit in addition to that ensures effective communication, both internal and external, because as you're managing internally, but also you have external stakeholders that you have to communicate to. So it puts up that inference that you have to use. Also, it establishes a common procedure for planning and management of resources by objectives. So it means that if something is being managed by the Ministry of Health, the same approach we are using, it's the same process that WHO should be using, or Africa CDC should be using, or any other agency should be able to fall in and with a proper communication structure and all that. So the features we have here is that it has its own features or characteristics, which including management by objectives. The span of control means how many people should be under your command. The modular organization in terms here, when we talk about modular, is whom do we need to be on this group? Not everyone is supposed to be on this group. And doesn't mean that if we say that you are in charge, it doesn't mean that you have to be either a director of a certain institution or you be the big person in the institution. No, it means that who is the most competent person to handle this? To be standardized with common terminologies. When we mean that by common terminologies, if I say that a signal, it means it should be understand what it means a signal is. If I say that we have an alert, if you know what it is. If I say we need to have an event, you should be able to define these words. So that common terminologies should be across. If we talk about that we're having, we say that we're having emergency operations center, all of us should be able to understand what an emergency operations center is. So all things that's what forms the common terminology. Things, common words that we use that are universal everywhere. Also, the another feature is accountability. Accountabilities on how we use the resources in terms of when we are deploying them and also when we bring them back. Then there's another issue of resource management. Resource management is what has been put in your custody, how we use them effectively to achieve a bigger output. So the core functions of IMS, look at the core functions of IMS is that it has about 5 core functions. Number 1 is management. It's responsible for the overall emergency management. And if it comes to the Ministry of Health, some of you were able to come there. In this time here, if we have the incident management, the management tends to be under the Director General, but who also delegates to give it what someone called the incident commander when the incident management has been activated. Then also have operations. At the field level, it provides direct response to the event. At higher level, it provides coordination and technical guidance. So here you have the operation officers. So someone will tell you that he's in charge of operations. So you know that he's trying to coordinate either pillars that have been activated, we get information from them, then this information is brought together to inform the incident management team about what's happening. Then we have also another structure called the planning. Because as you're working or you are approaching the event, you end up having so much information generated. So the planning component, it does data collection, they do the analysis, the planning of future actions based on the likely course of the event and the resources that are available. So the planning section is very, very, very important to have. The other section we have here is the logistics section, which acquires trucks, stores, and also stages, scenarios of how things are going to be moved. It maintains and disposes of some materials and resources, and also it provides the responders. So, for example, I'll give an example of the outbreak that we had in Bulambuli, where we had mudslides. So the logistics team had to mobilize tents so that they are well positioned in some spaces. Also, we had the Red Cross, which also tried to mobilize tents to be put in spaces. All this requires logistics section to be able to handle. Then admin and finance, all those things that I've talked about, they need money or they need finances to be supported. Cash flow management, tracking of materials and human resource costs, budgets, preparation and monitoring of production, and maintenance of administrative records. So the administration and finance, even those people who are being deployed, whether they are rapid response teams or emergency medical teams, they are detailed, profiled, and then given enumeration depending on their capabilities. So those are the sections that make up the incident management system and their functions. So I talked about that the incident management is managed by objectives. So here, you know what they call the incident action plan, which helps establish activities based on defined objectives. The steps for establishing incident management by objectives include understanding the agency's policy and directions, assessing the incident situation. When we talk about assessing the incident situation, for example, where is it? Is it in the urban city or is it in the rural area? Are there schools involved? Are there schools involved? Are there institutions that have large populations involved? Are children more involved than adults? Are males more involved than females? Are elderly more involved than the young? All that comes into assessing the incidents. Then establishing the incident objectives. What is our objective in this incident? Someone asked about the issue of Chitezi. For example, what would be our objective in Chitezi? When there was the collapse of the Chitezi, that means our objective was to look for every person who has the life in him and being extracted out of that and then given appropriate management. Then select appropriate strategy or strategies to achieve this objective. So maybe our objective would be to establish maybe type 1A or type 1B clinic within that area, to be able to manage these people, or whoever is being extracted is brought out, then given immediate care, then maybe referred to the appropriate center. Then also perform tactical directions. So tactical directions means that here you are using teams or specialized officers who are on the ground, who are in the field, that are able to provide adequate care or adequate management for the cases that may be involved. So the best example I can give right now, because we're in a Ebola situation, is taking a tactical team to Congo to go and manage the situation or providing care to the patients who are in Congo. So the tactical team is always on the ground. Then from the tactical, you got the operational team, which is a little bit more of paperwork or analyzing the information you're giving them, which also informs the strategy at the last point. So there is also providing necessary follow-up, and this follow-up is both unidirectional. It goes up the strategic area, and also it goes to the tactical teams that are on the ground. So the next slide. So we talked about that management of object. The incident must have an incident action plan, specific incident objectives, the activity to be completed, cover a specific time frame, hold an operational period. Because, for example, here in the government, we tend to have them either for 3 months. If we have completed 3 months and we haven't achieved our objectives, we can make 6 months. If we have given 6 months and we haven't attained our objectives, we give it 1 year. So we keep having specific time frames depending on the burden that we have. Then also it may be oral or written depending on the magnitude of the incident. But because we have we're having incidents that are really maneuverable, we tend to have actions that are being supported by other partners. And it's necessary that the incident action plan is written and shared across. Next, the span of control. The span of control looks at the number of individuals, also so that one supervisor can manage effectively during an incident. It's key to effective and efficient incident management. So you have to know that as a leader, you can't manage a number of people, maybe 500 people under your care. So the span of control states that at least every officer at every level should manage about 3 to 5 people. What does it mean? That if I'm a doctor and I'm a senior doctor, it means I should have a maximum of 3 junior doctors under me. If I'm a principal doctor, it means I should have 3 senior doctors under me. If I'm a commissioner, maximum I should have 3 principal officers under me. That's what it means, span of what? Span of control. How many people can you be able to manage? Span of control, considerations are influenced by the type of instance, the nature of the task, hazards and safety factors, and the distance between supervisors and sources the resources the supervisor needs to carry out that activity. So if we go down, I don't know, you will see that we tend to have the pictures on your right. The next slide. So if you look at the pictures on your right, the picture number 1 there is trying to show you that at least 3 people should be able to report to you. Other than the one which is a little bit down there that show that almost everyone is reporting to you. Once that one happened, it means that you are going to be overwhelmed by information. You're going to be overwhelmed by tasks, other than choosing one person to be one leader at a time that reports the other, which ends up solving a lot of problems during the outbreak. Outbreaks or incidents can be so massive that they have a lot of people in them, and all these people can't report to you. So it becomes necessary that you appoint managers for managers along the way. So next slide. So we're saying that how is the incident management organized? It differs from the day-to-day organogram structure and positions. It has a unique function role in a response organogram. Its uniqueness helps to avoid confusion over different position titles and organization structures. I explained this earlier on that the way the incident management system is organized, it's best that the best experienced person, what they call the subject matter expert, will be the one to lead the other colleagues. Then with that, it means that other colleagues can also follow in. It doesn't mean that if you have been a director of an institution definitely you're the subject matter experts. No. So remember, this is always ad hoc. So it may depend if, like, for example, an emergency physician, I can be better suited to manage an emergency response than going to bring, for example, a director in office of the OPM to come and manage the emergency operation. It may be a little bit quite different from that. So the incident management system doesn't directly reflect that someone has to be higher in position to be able to manage it, but the most subject matter expert is the one that takes over. Assigning personnel based on expertise, not status or position. Someone who is a director may not hold that title when deployed under the incident management structure. So you will know that if you are being deployed to respond, your positions in where you work, they don't matter here. What matters is action that's required. Your ability to work is required, not the position that you come with. So next. So although there is no hard and fast rules, remember that only functional positions are necessary or required or are established. Each established or activated function or position must have a person in charge, and an effective span of control must be maintained. So as you know that as we work, you keep activating pillars, but not all pillars have to be activated at once. So you may have some pillars. For example, in the ministry here, we have even 10 pillars. We have surveillance, we have case management, we have risk communication, we have logistics, we have continuity of essential services, also many pillars. But not every instance requires that all pillars should be activated. So we say that here in this case here, establish or activate pillars that are required for that instance. That's what they call modular organization. Modular organization, you activate all that you need. It is scalable. And also, for right now, I can say that since we deactivated, or we said we don't have Ebola anymore, some of the response pillars were also closed down because their relevance at that matter was no longer necessary. Thank you. Next. So you can see that an example of malaria incident management system. You see that their system starts with the chair minister, the chair minister of health, then the national task force. From the national task force, you have the scientific advisory committee. From the advisory, as you come down, you have the incident commander. Then also you have the finance and admin. Then the continuity of routine malaria activities. But under the incident commander, there are so many pillars that have been activated at that level. There are so many pillars that have been activated at that level, but also under those pillars, you find that also there are some sub-pillars that have been activated. And this is an example of modular. Now, in this kind of arrangement, not all these structures, not all these sub-pillars or pillars are activated at the same time. So you may find that maybe you may start with activating maybe surveillance and case management, and then strategic research and information, or maybe you can start with it, or this communication and community engagement. But you may find that if you're in Usoga region, you may find that you have some resources that are there. But later on, you realize that after maybe 1 week, the resources are no more. You may end up now activating the logistics pillar so that they coordinate resources from everywhere in other regions to come and support you. But also, as you go down, you find that within the pillars, there are also other sub-pillars. Like, look at the case management and preventative therapeutics. You have clinical management, preventative therapy, or EMS. So you may find that at the time you're seeing these patients, you may not be requiring EMS. Maybe you're managing those that are already coming in the facility. But as information comes in, you may find that now you need to activate emergency medical services, either pick patients from the communities and ferry them to the treatment centers. So move down, also can say another example. So looking at also COVID-19, you'll see that during COVID-19, you see that the other first one there, the minister was the highest, but during COVID-19, it was the president, then the parliament, then the national task force that were activated. And this time round here, the national task force that was activated was at the office of the prime minister. In most of the other cases, you'd find that we only activate the sector-specific national task force. Then we also have the policy and strategic level, which is now chaired by the minister. Then you have the scientific advisory committee. Then also you have the chief of staff with the Director General of Health Services that also works with the incident commander, and also then also activates the incident commander has other sub-pillars that have been activated under him. Again, coming to case management, surveillance, strategic information and research. Then you also have risk communication, logistics, and all that. But also the other parallel structures that are also activated along the way, including like cross-border engagements, because we're having people coming from outside the country, that also these ones need to be activated. Next. So the concept of operation, look at the concept of operation is that if I have activated the incident management, it has a concept of operation. We start from the strategic on top, where we have the executive, the president, we have the National Emergency Management Authority. Here we always have this is the handled by either NECOC, National Emergency Coordination and Operations Center, and the Office of OPM, but also that's at the level of the strategic. We can come at the level of the national, at the level of operations. This one here is responsible for effective coordination of all responses. We can have sector-specific EOCs like in the Ministry of Health, or we can go down and have those that we need that combines all of them, but most especially here in the country, unless it's necessary, but we tend to activate sector-specific. From the operation, also we go to tactical. These are close as close as the incident as possible, usually in the field. For example, when we had monkeypox in Nakasongola, we had to have a field level emergency operations center. But now we're trying to functionalize them, call them emergency operations, we call them alert desks in the districts. So this is the concept of operation which we use most of the time, where we have the tactical side, which is at the field level. We have the operation side, which is at the level of the sector, and have the strategic, which is the level of the executive. Next. So this one is trying to explain what happens at every level of the strategic, the level of the strategic, where members of the IMS need to operate from the FIOC, staff from other sectors or responsible partners and donors may not at all need to be provided at the EOC, but however, they can be worked with in the presence of a liaison officer. At the level of the liaison also, the liaison officer, the level of the operations also, the liaison officer should maintain a coordination, communication, and information sharing, not only with other EOC sector, but also the National Disaster Management Authority, but also with other responsible partners and donors. Then also at the level of the strategic, the FIOC also maintains the coordination and communication with the tactical level, the EOC, and also the people in the rapid response who are in the field. So it has also that notion that it can be taken into consideration in terms of reporting. Next. So at tactical level, you saw I told you what we have there. We have the rapid response teams, which are in the field. You can see that circle. We have rapid response teams. These are always multi-sector, but also we have the emergency medical teams, which are specialized officers that are purposely designed to handle that incident in terms of clinical care mainly. But when we talk about rapid response teams, these can be social scientists, can be epidemiologists, epidemiologists, public health experts, water experts, environmental experts, all that comes into that tactical team that goes to the field to establish the cause and manage all public health interventions that are required for it. Next. So someone asked that how best can we manage some of these situations when we are in resource constraint and in the field? One of the important things is meeting management. So in a meeting management, you have officers that are responsible for coordinating these meetings. So we have officers to manage before the meeting, during the meeting, and after the meeting. So during the meeting, you have to know what are the objectives of this meeting. You have to define the objectives of why you want to meet. Then we create and distribute the agenda in time before the meeting takes place. Then we schedule the meeting in terms of where it's going to be, at what time, and when are people required to leave for the meeting, because sometimes that don't have to take the whole day. Then during the meeting, run the meeting, but also keep it in time that you suggested earlier on. Don't leave that meeting without assigning items to who is responsible and the duration that this person is supposed to give us feedback. Then we have to create, then after the meeting, create and distribute or archive the minutes that are required. Then lastly, you have to evaluate the impact of the change that has been created by this meeting. So once you are into incident management, meetings can't be avoidable. You must have meetings, receive information from the people who are in the field, and also must have the meeting to give feedback to the people who are in the field, or even other agencies that need to know what's happening. And all that is done in the meeting room or meeting areas. You refer that even in the worst space during an outbreak, and a meeting area is designated where meetings are going to be taking place, and the time, whether either the tree or other, but at least a space is designated, the time and the coordinating officers are always there, and the secretariat that's handling these meetings. Next. So by way of summary, I was saying that successful emergency management requires effective management process and structures that supports competent decision-making, timely process of information into action, rapid deployment of resources. IMS, the standard management approach, helps meet the demands of the successful emergency management by ensuring effective coordination of information and resources. We have said that emergency management within IMS is managed by objectives and with a manageable span of control. And also I've said IMS differs from the routine structure and uses unique functional roles with clearly defined responsibilities and accountability. IMS has a clear concept of operations with defined operating picture in the 3 levels of strategy, operation, and tactical. Otherwise, thank you so much for listening, and we shall go ahead to answer some of the questions that have been posted. Thank you so much. Back to you, Chair.
Wow, thank you so much, Dr. Chithula, for such a wonderful presentation. Yes, we upload you like everybody is doing on the call. The time is now. We will give an opportunity to 3 people, a question for each one of the presenters. You can put up a hand. I know many of the questions have been answered in the chat, but if you have a question that you want to address to a particular presenter, okay, we shall begin with Betty. Betty, you are unmuted now. Please go ahead and mention the person you are addressing the question to. Thank you. Betty. Betty, please unmute.
Hello,
Oh.
Can you hear me now?
Loud and clear.
Thank you very much to the presenters. I have a question actually for the first 2 presenters. I wrote my 2 questions for the first presenter in the chat, so hopefully they'll be read out. I also have another question for Professor. She talked about preparedness, and I was wondering, what are the most common gaps that you see in preparedness plans? Also, I am curious, in Uganda, are there strategies in place to address the psychological impact on both the first responders and the survivors? Thank you.
Thank you, Betty. Professor has taken note of the question. I'll give a chance to Celine Atieno to also ask a question, hopefully to be for Mr. Juma or Dr. Chithuli.
Okay, good afternoon here in Kenya. I'm Celine, a community health professional in Kenya, Nakuru County, Rift Valley Province. I've just posted three questions on the chat, but at least I can ask one as per the facilitator just mentioned. My question goes to the second presenter, the professor. Madam, about on equity versus speed. Under life-saving first and equity and fairness, how do we balance rapid triage with ensuring vulnerable groups like children, elderly, and PWDs are not deprioritized in chaotic settings? And maybe on sustainability also, for sustainability, minimizing waste and environmental impact, what practical examples exist in Africa for this disaster waste management after medical supply distribution? Thank you.
Thank you, Celine. I'll give a chance to Prof to respond to the two questions. And afterwards, we shall have the other questions for the other presenters. Thank you.
Okay, thank you everyone for the active participation and all. So I'll respond to Betty first. So she asked about the strategic plan and what are the challenges during application. So when we usually develop a strategic operation plans, mostly it will look good on paper, but when we try to apply those things, we might identify some gaps. So these gaps might be identified when we do trainings, when we do different type of drills. That means it might be a tabletop exercise or it might be a functional drill. So when we test those things, we might see gaps on coordination, we might see gap on communication, and then we might identify that the resources we have doesn't match with the hazard we have. So you might have excess supply of unnecessary materials, excess supply of professionals, excess supply of system, but you might not need that for the particular hazard that you wanna manage. So what we usually do is have the plan drafted, give a proper training, and then do frequent drills or exercises. You can do it like twice a year, or it can be done in a yearly manner to identify the gaps. And then based on the identified gaps, you can try to manage or to try to rearrange the SOPs so that it can be more effective in managing those disasters. So I think that's my response for Betty. And the second question was on what?
Celine asked
can you repeat
about
the question, please?
prioritization for people with disability, the children, in case of emergency, how can they all be catered for? Yes.
Okay. So when it comes to triage, you have to what? Triage patients based on the severity. That means those that are gonna need airway management should be managed first, followed by those who are in shock, and then those who have altered mental status. So we have different triaging modalities that are the START and the SALT triage systems. You can use them in your setup and then pick the one that is suitable for your situation. And then during triaging, there is always an over triage, and then there is always an under triage. That means over triaging means, let's say you triaged a green patient to the red side. What's the problem with that? The patient will be what? Managed, but you're gonna waste resources, right? And then those resources that are gonna be used for immediate patient will be wasted, right? But the patient's life, it doesn't affect the outcome of that patient. When we come to the concept of under triage, let's say you triaged a critical patient to a minor side, a green side, or a yellow side. what's going to happen to that patient? The patient is going to expire, right? And then you didn't intervene timely. So that's going to cost what? The patient's life. So when you use a triage modality, you have to what? Analyze which is best for you, or which is easy to implement and which is less cost effective. So take it into the concept over triage and under triage. So when you triage patients, you might what? Miss some of the elderly, women and things like that. So we assess based on the severity of the illness. And then after assessing based on the severity of illness, we go to those disadvantaged populations. We're not going to ignore them, but we're going to assess based on the medical presentation, manage accordingly, and then transfer to the possible or to the ideal hospital. So I think that's my response.
Thank you very much, Prof, for that. The CPD link has been shared in the chat. For those of Uganda Medical and Dental Practitioners Council, and then the Allied Health Professionals Council, please fill in the link, put your identification number with the council. Nurses and Midwives Council, still fill in the link, but we are not yet in position to submit this CPD to your council, but it'll be done eventually. Yeah, but still fill in your details. Thank you very much. We have now Francis Ouma. Please ask your question. Unmute and ask your question. Opondo Francis Ouma. You can unmute.
Thank you very much, Doc. Mine was already answered. Thank you.
Okay, very nice.
Very nice.
Any other question for our presenters? Any comment? Most of the questions that appeared in the chat, they were responded to. Okay, we have Santrina Mugisha. Please unmute.
Yes, hello. I wanted to ask and to be pardoned about the CPD point.
Okay. For the Nurses and Midwives Council, we've not yet integrated the registration system from our side as the ECHO sessions. So, but you can fill in the details, but we're not yet in position to submit them to the council. But when the time is ready, we'll submit your CPD points to the council. So everybody fills in with your council registration number. Okay. Any other question? Okay. Mr. Juma is going to give some response.
Yes, so there was a question from one of the people asked that, how about mental health of providers and affected people in disasters? So I think it's been an oversight in most of the responses. Mental health, as you can even go back to COVID-19, issues of mental health in the ICUs and related things. But it's been an area of growing interest, and some of the main responders we have in Uganda, like the Uganda Red Cross, are now increasingly having mental health experts and practitioners in their responses. So I think there is a growing realization that this is needed. And also, of course, as the responder or as someone in this situation, to also be aware that the situation can actually affect you, and also the idea of because you are interfacing with a situation that's rapidly changing, like every time there are no resources, you can't help these people. and in one or the other you feel guilty and all those kind of things come in. So it's a growing area, and I feel that whoever is operating in disaster response needs to remember that they also have a life at the end of the day. And also there was a question about the protocols and all those. So one of the things we have is, if, for example, you haven't responded to an emergency in 72 hours, so what are you responding to? Like they've said there is a landslide, and in over 72 hours, you are not on ground, you haven't done anything. So exactly what are you doing? So you find in organizations like the Uganda Red Cross, where they have some of those protocols, the response protocols, they have the time. We must respond within 72 hours. And then also when a disaster happens, we do an assessment called the rapid needs assessment. So like, how many people are affected? Where are they? What are the immediate needs now? What are the resources, extent of damage? How many children, women, persons with disabilities have been affected by this disaster? And then, so you avail that information so that everyone knows. Then you have your incident command system. So they all know that this is the situation on the ground. So, and it's usually important that that is given within 72 hours. Otherwise, it will be too late and the needs will have changed. You'll have missed the responding in the emergency phase. You'll now be responding in the next phase. So, which is usually a challenge that people have here in Uganda, that government is sending the blankets 2 weeks after the flood. And then so people are having those challenges. So I think it's one of the important things. And then, of course, ethically, we have the sphere standards that help to, in distribution of resources, how much square space can you give to someone? What is the minimum amount of water you can give to someone in an emergency? What's the minimum amount of food? So those help so that quality is maintained. Even when someone is in an emergency, they are still a human being with their dignity. So there are those standards, and to the best of your ability, you have to at least ensure you adhere to the standards. Of course, although some disasters, some situations make it difficult to do that, but to the best of your ability, the standards are there for the care and services that we provide in disasters. Thank you.
Wow. Thank you so much, Mr. Juma, for such a wonderful summary or conclusion of your earlier presentation. We have come to the close of our 120th ECHO session with SEED Global in partnership with Emergency Medical Services Department at Ministry of Health. I am so sure we are not the same. By the time we began this session, we are at a different position now in terms of disaster management preparedness. I will invite Dr. Chithuli to give his parting shots in 30 seconds, and then I'll invite Juma to do the same, and then Prof will wind up with parting shots. Dr. Chithuli, you're welcome. To give your parting shots. Okay, maybe Mr. Juma, you can give your parting shots.
Okay, thank you. So really, my hope is that our attitude and understanding has greatly shifted, because in some of these situations, it's not the normal, you don't have your normal table, your normal situations and all resources that you have, and yet you must save lives. And as Dr. talked about the incident management system, if a disaster happens in a place and you are the one there, you are the incident manager until the other people arrive whom you expect to have the mandate. So I hopefully that what we've shared today will help us to save lives of our communities. Thank you.
Thank you very much, Mr. Juma. Prof, parting shot.
Okay. Thank you, everyone, for the participation. We have learned from each other, and then we will continue learning, and then prepare, and prepare is our motto. Have a nice day.
Dr. Chithuli, kindly give your parting shots. After Dr. Chithuli, I will invite us to turn on our videos so that we can see your faces and take our group photo. Dr.
Okay, thank you, colleagues. Thank you, colleagues, and thank you, everyone, for this opportunity. I'm glad to be part of the team. And also for the people in the studio, thank you so much for that wonderful work you're doing. Time flies very fast, but I hope we're able to try to summarize a lot of information in a short time. I know incident management system is a 1-week training, but I know some of you may have access to WHO material, Africa CDC material, to learn more about incident management systems. But they are practical in nature, and I want to encourage every student to utilize those platforms to learn more. And also, once in a while, come and participate in responses, and you understand how these things work more. Otherwise, I'll wish you the best for the weekend. Thank you so much.
Thank you so much, Dr. Chithula, representing the Ministry of Health. I'll invite all of us to turn on our videos. We'd love to take a group photo. Please turn on your video before you sign out. Thank you. Thank you. Mr. Pondo, Francis, and Trina, would love to see your face. Wow, that is wonderful. Thank you all for coming through. Lovely, lovely. Wish you a very wonderful weekend and see you in 2 weeks' time. Bye-bye for now.